feedback from you guys. So, questions for our panel?
We've seen a number of those ideas. I would start with the Minute Clinic concept, which is a viable concept. The reality is that if there have been a proliferation of companies coming into that space, volumes have just not been there. They haven't, and a lot of those companies are going out of business, and even the ones that have been, I guess, quote-unquote successful just have not come close to meeting what they thought they could do in terms of volume. So I don't know what it's saying, but the reality is that they've been very slow to ramp. There have been too many of them, and the fundamental unit economics of them don't work at the volume levels that are currently out there. In terms of medical tourism, we're beginning to see some interesting concepts in that space, but it is still very early, in my opinion. And once again, when you get back to the volume levels that can really achieve a business of real scale, we're a good bit of ways from that right now. Not to say it won't happen. We had a St. Kitts Medical School concept the other day, and we're seeing a company that is helping get people to Central America and Asia in terms of doing procedures in those markets. So I think it'll happen, but when you look at the scale and the volume of that business today versus where people thought it might be even a couple of years ago, once again, it's much, much slower than you would realize.
Yeah, I guess just to echo that, the money isn't there in those minute clinics to really have an impact on both access to care and the cost of care. The volumes just aren't there because the model isn't what consumers want. Medical tourism actually, though, is an interesting proposition, not that the volume would get large, but the threat of the volume would get large. I'm reminded of a story where the hospital administrator in Birmingham, Alabama, was complaining to a friend of mine that there was no competition in healthcare. He said, "What do you mean?" He says, "Well, we bid for all the auto workers to fly down from Detroit and come to our hospitals for heart disease. And the minute we did that, all the hospitals in Detroit lowered their price. See, there's no competition," which, of course, is exactly what competition is intended to do. So the notion that it's out there, I mean, obviously the number of diagnoses that you can use that for, and there's a lot of limitations on that market, but the fact that global competition is there is likely to put additional competitive stress on hospitals in the United States.
So we have one last question. Right here.
Eric Langley with My Managed Backup, although my question has nothing to do with DR. I'm interested to take that one step further with maybe virtual clinics where you'd be talking to your doctor online, you've got a sweatshop full of room of doctors in wherever where you're not actually having to travel to the facility, and maybe you do your testing locally, but your consultation is happening virtually.
Yeah.
Is that even happening?
It's a great question, and I certainly do see that growing. That's just part of a smart society. That's part of consumerism for sure, and even the companies that are in that space continue to grow. And I certainly see secure online visits. And there's some policy changes that we have to make in legislation to ensure the privacy of that transaction. But for the most part, that's all been shored up, and I certainly see that growing. And you'll see a few more companies probably emerge in that space, and you'll see the companies that are currently operate in that space grow. Companies like Relay Health that McKesson has. So.
I was going to say on that too. There's sometimes pretty explicit state laws that prevent that from happening across state lines. And in healthcare, being Georgia State or Emory or these, we all worried years ago about the internet and everybody taking courses at Harvard or California, wherever, Georgia, whatever they want to go, and it was always that big concern. And I think and so all the universities sort of boomed in that area, and I think that's tapered off quite a bit. I mean, there is that sort of, I worked at the American Medical Association for a couple of years. There is that sort of relationship sometime between the physician and patient that's been pretty sort of strong and a pretty good bond, at least for the most part. And so I would think there'd be some interest, there's some potential to do that, but again, it's back to the mini-marts as well. I think there's some demand for it, but I don't know if there's enough to sustain it.
Yeah, we think it's an interesting area. We've definitely looked at a few concepts in that space, and whether you're down to the individual level and their relationship with the physician, I think where we're seeing it is sort of a cost-saving outsourcing play for hospital delivery systems that frankly, if you look at rural hospitals, for example, in psych or in stroke, obviously ReachCall, a company that I'll put in a plug for one of TAG's top companies, you're beginning to see it, and we're beginning to see a really interesting recurring revenue model and an economic model that can work for an early-stage company. So telehealth, the technology's here where that is actually starting to get pretty interesting.
Yeah, no, actually, I'll just tag on to the policy aspect because there is a policy concern when you go state to state. That's something. Intrastate, you're fine if you're talking just in here in Atlanta, but if you try to cross state boundaries with any healthcare information, PHI, certainly you do have issues to work on. That's something actually we're trying to tackle nationally as well, because we're trying to get more uniform standards there so we don't have blocks when we're trying to share information. When you're traveling, you might be in Hawaii, but you live in Atlanta and you can't transfer information. That's a significant problem. That's a problem with interoperability, and that's something else that we're tackling in the healthcare sector on that level. So,
think about this maybe as a paradigm shift that can actually, where this technology, which is available, can, with companioned with some policy changes, can make a dramatic cost reduction. So, if freestanding emergency rooms were licensable in every state, if you could have a freestanding emergency room, which means it's an emergency room with some diagnostic stuff attached, we could replace every critical access hospital, but a few in some truly remote areas, with a freestanding emergency room with telemedicine to provide the specialty care and mid-level providers delivering the hands-on care. How much money does that change and provide that medical expertise in rural areas that don't have it? There's no way to get those people paid for a telemedicine consult. That's very difficult. You can't, the medical center that's in Memphis, Tennessee can't serve that purpose in Arkansas because of licensing issues. The privacy issues come into play. But this is a place where technology and policy and innovation can change the game and improve access.
I think I've been told we have time for one more. So,
one of Kurt's positive comments came out of investment in EMR because of e-prescribing. So this is a two-part question. How important in the short term do you think e-prescribing is as a stimulus to continue and help in some of the things we've been talking about? And number two, what do you think we need to do here in Georgia from a policy perspective to better shore up that e-prescribing can actually be used more universally?
So EMR and e-prescribing.
Yeah, I think that I worked a lot on the e-prescribing incentive, and so I think that's certainly a big plus. It's a start. It's only a 2% increase, but if you add on some PQRI, which is a physician quality reimbursement increase, or incentive, that's another 2%. So that's a 4% increase reimbursement incentive for utilizing technology at the point of care with your patient. So that's a great start. It certainly got a lot of attention. It's added a lot personally to my company, but also to our industry. And I think brings a lot of value to the patient. I think that we will continue to see that. That's part of what the $10 to $20 billion incentive over the next 2 years in HIT will come from. You could see anywhere from a 4 to 5-6% increase for in Medicare reimbursement, and hopefully the private payers will follow suit. I certainly see that from a state standpoint. I think that obviously the coffers are not full, and so it's tough to start speaking on the state level without when we're having cuts across the board. But I think that you do need to incentivize at the state level. I think that setting aside money to incent physicians, whether it's payments even as low as $3,000 to $5,000 per providers that adopt technology at the point of care, not to buy technology, but to adopt it, because the ROI downstream doesn't come until you adopt technology, not just buying it. It's when you utilize it at the point of care. And so I think that's where the state can step in and assist. I think the federal government might hopefully be around the $15,000 to $18,000 range, $20,000 range per provider, hopefully. And I think the state can kick in a little bit there too.
I was going to say, at least on e-prescribing, I've been working with a project in Florida. It's a Medicaid, psychiatrist, and they've sort of, it's the Medicaid program has been on the to the less expensive side, but they've basically given the PDAs and given the training to the physicians. And the ones that have gotten it have loved it and like it. I mean, really, you can see where they use it, and really, it has I think a great trajectory. And, in getting ready for this, I was reviewing some of the medical residents and trainings we're talking about, for example, use of the Internet and things like PDA and de-prescribing, electronic medical. And you can certainly see a future, a different, if you will, generation than the current set of physicians in terms of using or looking at those kinds of opportunities and those technologies and seeing them as a real advantage in terms of what they do or what they're looking for.
Great. Well, I imagine we could probably talk about this for a couple more hours, but I'm sure people had to get to their offices. So anyway, let's thank our panelists, and